Hello, everyone. It's my pleasure to introduce today's speaker, Dr. Lee, who is a proud McGill MPU graduate. He obtained his master's degree in 2010 and his PhD in 2016, both from McGill University at McGill MPU. And he worked under the supervision of Dr. Issam El Naqa on machine learning models for radiotherapy toxicity prognosis. And he did after his PhD, he moved to New York City to complete a 4-year residency program at Memorial Sloan Kettering, and he stayed at the MSK after graduation and has been working as a faculty physicist. And outside of his work, he enjoys to do other activities like cycling and rowing. And help me welcome Q's today, and I'll let you speak, Q. Welcome.
Yeah, thank you, Norma, for the introduction. And it's always a pleasure to return to Friday noon seminar. So, okay, nothing to disclose. So let me add to Norma's introduction of me on why I'm giving this talk. So but myself, I have background in data science with the machine learning from my research years. And I got into the motion management business after I started my job as a faculty, and I've been a member of motion management physics group at Memorial. And the highlight of my career was to lead the first skating treatment at Momo's campus, which is one of the satellite of the MSK system. So although I have some years of experience, I don't call myself a world expert. So why am I giving this talk? Because I think motion management for, especially for upper GI, like liver and pancreas, is one of the most challenging areas in radiation oncology. I don't see you guys on the camera, but I hope many of you will agree if you have clinical experience in this area. So my interest is really about how we can apply data science or AI to improve our motion management practice. But before I get into that, I hope there's a good number of students and residents. So I want this talk to be educational. So I'm going to introduce what DIBH or deep inspiration breath hold is, and then I'll introduce our DIBH workflow at my hospital, MSK. And finally, I will talk about the quality improvement projects going on at MSK, which are led by myself and my colleagues. So we begin with liver and pancreatic cancers, which are amongst the lowest survival rates according to the 5-year survival rate from UK. And dose escalation is known to improve the survival for these cancers. And this study show if you increase the BED to a liver tumor by more than 80 gray, it clearly shows survival benefit. But the obstacle is the uncertainties from the respiratory motion that can affect the accuracy of dose delivery to liver and pancreatic tumors. So there are 5 main ways of motion management for interfractional respiratory motion. And MSK, we use 4 of them, except tracking. And due to the limited time, I'm only going to talk about deep inspiration breath hold. But if you have any questions about gating, abdominal compression, I'm happy to answer after the talk. So what is DIBH? So at DIBH, we have a patient inhale breath at a specific level, which is determined during simulation, and have the patient hold the breath for the duration of imaging and beam delivery. We also have expirational breath hold, where patient hold at expiration instead of inspiration. And this was shown by some studies to improve the stability of target position, especially for liver cases. But it was shown to be less comfortable for patients to hold it too long. So the objective of DIBH is, of course, reduction in tumor and OAR motion, improve image quality by reducing motion artifact, and it doesn't really apply to GI cancers for breast. It increases separation between chest wall and heart. So there's advantage in inducing anatomical change by deep inspiration. Not really applicable to GI cancers, except that when the tumor is close to lung, expanding lung volume will decrease the fraction of the lung irradiated by high dose. So there are three main components of DIBH. So first, we need a way to get a patient to hold their breath, so patient involvement. And surrogate is what we can measure easily to track patient breathing. And we can feed the surrogate information back to patients as a feedback. And the surrogate can be sent to the machine to stop the beam when the breathing is out of the window that we set. And of course, what we are treating is internal anatomy, a tumor, which is not a surrogate. So we always need to establish correct correlation between the surrogate and the monitoring so that the surrogate is a reliable surrogate for the tumor that we are treating. So there are two main ways to implement DIBH. So the patient can voluntarily hold at the designated level, the voluntary breath hold, or the breath hold can be assisted by an external device which stops the airflow when the breath hold level is reached. And so whichever method that we use, some kind of coaching will improve the reproducibility of the process. So the study by Servino shows when we give patient a visual feedback of how they breathe, it improves the reproducibility of the DIBH. So there was a clinical trial that compares voluntary versus assisted DIBH in UK. It was a randomized trial done on breast patient though. And when you compare voluntary versus assisted, the reproducibility of the chest wall position was comparable. However, the setup time and cost involved was more for assisted DIBH. So the paper concluded that voluntary DIBH is a cost-effective solution. However, there's no trial that exists for abdominal cancer patients yet. So about the surrogates, there are different surrogates that we can use. The easiest way is to track the motion of the abdominal wall. So we can simply place a marker on the chest wall or abdominal wall, which moves mostly in AP direction with breathing. And there's a camera that reads the motion of the marker, which we can use as a surrogate. Or there is a surface guided solution which captures the whole abdominal wall instead of a single point from a marker. And spirometry measures the airflow. It's actually measuring the speed of air from which we calculate the lung volume. And spirometry can be used for assisted breath hold. And of course, it's important to monitor the internal anatomy because surrogates is just surrogates. So the most popular method is onboard KB imager because most of the modern linacs are equipped with OBI, and we can simply trigger the imaging during beam delivery using MU or gantry angle as a trigger. And OBI can give you two-dimensional shift information, but if you use MV at the same time, it can triangulate to give 3D shift information. But OBI requires something that OBI can detect. So usually there's a fiducial stent that is implanted before simulation, but it's not always possible. So that's the limitation. And similarly, stereoscopic KB imager also is KB based, but it uses external KB sources, uh, and it can give 3D information typically by using two sources going in orthogonal directions, so we can triangulate. But it also requires implanted fiducials as surrogate. Finally, MR ultrasound. I don't know if McGill has MR Linac, but the coolest thing is that we don't need implanted markers, because MR ultrasound has a soft tissue contrast, and the tumor can be identified in real time, which can be used as monitoring or gating. So there are many challenges in DIBH. First, some patients are not really compliant. Also, there are many uncertainties, which is important to point out. First, there's intrafractional variability, which means the uncertainty within a single fraction. So there are different sources of intrafractional variability. So this is a typical threshold where patients go through several rounds of thresholds, and the patient don't always make consistent threshold from round to round. So this difference between the threshold level between rounds is referred to as threshold variability. And even within a single threshold round, there's a fluctuation or a drift in the surrogate signal called intrafractional variation. And this variation don't necessarily mean that tumor will move within the threshold. It can be a noise from physiological changes. And lastly, there is a phenomenon called baseline drift. And this comes quite often, so I have a separate slide about that. Secondly, there's an intrafractional variability, which refers to the difference between two different fractions in terms of the threshold level. And finally, there's always uncertainty in correlation between surrogate and the target motion. So how can we address the challenges? So compliance can be improved by coaching, or we can come up with a screening to select a patient that is unlikely to tolerate the IBH and to provide alternative management. And in terms of uncertainties, so intrafractional variability can be reduced by effective coaching, as shown by several studies. Or we can just incorporate these uncertainties into internal margin. So we give the margin to to account for this possible movement or say residual motion during the DIBH. Or interfractional variability is easy to fix if you have a daily cone beam CT correction. And what it cannot correct for is the relative motion between fraction to fraction in terms of OAR positions. In that case, we can give margins to OARs at the treatment planning stage. And lastly, the correlation between surrogate and the target motion that can be monitored during imaging, during treatment through on-treatment imaging. So let me talk about a couple of studies that investigate these sorts of uncertainties. So this study by Zhang et al. Studied a group of pancreatic patients driven by infrared marker. And what they did was to measure the residual motion by identifying the implanted fiducials in trigger KB. And this is the distribution of the internal motion from these triggered KB images. And one standard deviation of this motion was 3 millimeter. And from this data, they recommended 3 millimeter margin, internal margin, so that this motion can be taken into account. And second study by Boda Hageman, they studied a small number of liver patients, and they had the ultrasound images where they were able to find a tumor, and they tracked the motion of the tumor during treatment. And what they studied was the relationship between the length of each breath hold and the internal motion. And they found that if the patient hold their breath more than 50 seconds per each time, it induced more internal motion or localization error. So their recommendation is to have a patient to hold their breath no more than 15 seconds, which makes several short rounds of DIBH so that the internal motion can be minimized. So baseline drift it can be important when you use the abdominal wall as a surrogate. So baseline drift refers to a posterior drift of abdominal wall over time. And the reason for the drift can be physiological. Say when the patient first comes in, lie down, it takes time for their abdominal muscle to relax. And while they relax, the muscle, the relaxation of the muscle makes the abdominal wall to settle in a posterior direction, or it can be caused by change of gravity or sleep. Some patients fall asleep during treatment, and we can see it by this posterior drift of the signal. And this study by Jensen studied a group of breast patients, and they monitored the position of sternum during free breathing. So the first 5 minutes or so, I don't know, for some reason the drift was high, drift was lower for first fraction, but for subsequent fractions, they found that the chest wall drifts posteriorly until like 4 or 5 minutes, and the drift can be quite significant if not corrected. It can be as large as 2 millimeter in some cases. So the remedy is to have a patient relax in free breathing for at least 1 minute, and that's recommendation by Sorbino et al. So that the relaxation of the muscles can settle down and there will be minimal baseline drift after that. Or this baseline, what I mean by baseline is the signal at max exhalation, which sets the signal zero. So we establish the signal zero right before we begin our treatment so that the baseline drift is corrected. And of course, it's important to keep monitoring internal anatomy. And when you see a drift, we go back to imaging and make couch correction if needed. Okay, so now I'm going to talk about how we do DIBH at my hospital. So a bit of a background of MSK. So we consist of 9 campuses across New York City metro area, and we are all in Barian system. So we are quite busy clinic, and our patient volume is quite high. We treat more than 100 patients, abdominal cases per year. And most of the cases are treated in TrueBeam, but we have limited number of pancreas or liver SBRT on MR-Linac. So to be able to treat in a uniform quality across 9 campuses, we implemented one MSK philosophy, which consists of standardized policies and procedures across the 9 campuses. And in terms of machines, we have a matched TrueBeams across 9 campuses so that patients can easily be transferred between campuses and the machines without a need for modifying the plan. So this one MSK philosophy gives flexibility for patients so that they can be treated in their preferred location. And that was very effective during, especially after the COVID, when there was a demographic change from the city to the suburbs. So let me introduce the system that we use, the product for motion management. The question to the audience, do your clinic use RGSC or RPM? I know McGill is Varian system. I don't hear anything, so let me just go over it briefly for the people that are very familiar. So RGSC is, as I mentioned, it tracks the abdominal wall by placing the reflective marker on the patient belly. So at the simulation room, there's a camera that tracks the motion of the marker, and this motion is recorded and during the scan and sent to ARIA. And at the treatment planning stage, the window, the gating window is set based on this trace from the simulation, or so-called a reference trace. And the trace is sent to a LINAC, and the patient setup is the same as simulation. And there's also a camera in LINAC bolts that tracks the marker in the same method. And the RGSC system comes with a visual coaching device where the patient breathing signal or trace can be shown to a patient in a small, like iPad-like screen. And patient has to breathe in to make this white bar to stay in this blue green section. And this RGSC system has advantages and disadvantages. So it's of course a variant product, so it's compatible with our Linux. So the integration from simulation to treatment is seamless, and the efficiency is very high. All you need to do is to place a block. There are more to it, but compared to spirometry, the setup is much more convenient. And I heard during COVID, spirometry was not a popular method for patients because they are concerned about the mouthpiece that they have to bite. And although the mouthpiece are sanitized every every time they use, patients were still concerned about the extra procedure. But compared to that, RGSC is simply a gating block on the belly, and that's it. And another advantage it has is compared to surface-guided system like LNRT, we want to use onboard imager during treatment so that we can monitor the internal motion or surrogate internal motion or fiducials. But when you pull out the imager, the surface-guided system cannot see the surface, whereas for RGSC, there is no such interference with onboard imager. However, as I mentioned, RGSC can be sensitive to block positioning. So where you place the block, the signal can change. And there can be noise due to involuntary abdominal wall muscle movement. Even cardiac motion can affect the signal. So the signal from the RGSC system can be noisy, which means that the signal is not always correlated with target motion. So let me go over our clinical workflow for liver or pancreas radiotherapy. So at consult, so our standard practice is DIBH for liver and pancreas, and if they cannot tolerate, we use gating as a backup, and free breathing is the last resort. And so DIBH, the use of DIBH was mentioned during the consult, and the patient are supposed to watch the educational video before they come to simulation. So at simulation, patient comes in, and the first step is to place a marker block, and we have a standard location for the marker block, but still we always mark the location of the block on a mold, and we also document the location for reproducibility. And then the patient takes 3 practice breath holds to assess their ability to hold their breaths. And from their practice, therapists determine the gating level and window at 3 millimeter width. Then we inject contrast and take 2 DIBA scans. The reason that we take twice is because these 2 scans are in specific timing from the contrast injection. So comparing these 2 different images with different contrast agent contents, they can get some biological information from it. And also the first 2 DIBH scans serve as a backup in case the first DIBH is not very good. So this is a typical breathing trace from a single simulation session. So it consists of a free breathing part, and there's the first DIBH, then some break in between, and the second DIBH. And these traces are sent to ARIA, as I mentioned, for treatment planning purposes. So the planning stage, So fractionations, of course, it depends on the disease and OARs, but the most common fractionation is 15 fractions, 2.5 grade to a microscopic disease, and 4.5 grade to a gross tumor, or we call it ablative, given in simultaneous boost. And this so-called ablative PTV, we have a formula for drawing it. So we draw the GTV, expand by 5 millimeter, which considers the internal motion and also interfractional variability. After 5 millimeter expansion, we subtract the OAR volumes with some margin. And the philosophy is to give as much dose as possible to GTV as long as the normal tissue tolerance allows. For contouring, what's special for GI cancer is we convert the isosceles lines into structure set to help evaluate OAR dose on cone beam CT. And planning technique is usually 6 MV VMAT between 2 to 4 partial or full arcs. And the dosimetries and physicists are supposed to check the breathing trace from simulation. And this is a very important step because many times we caught errors in the consistency between the trace and the gate window. So the trace in the gate window is verified at this planning stage. So at treatment, the first step is the same marker block placement, and they use the cast line to place the block exactly at the same position as simulation. And treatment starts, and the standard is to use on-treatment monitoring using, before I go to that, there is the verification step called fluoroscopy. So what it does is before we begin the treatment, we turn on the fluoroscopy for like 5 seconds, and we make sure that during the few seconds of breath hold, the internal fiducials are staying within the reference position. And then we take gated cone beam CT for couch correction. And this is what I was talking about on treatment monitoring. So we use trigger KB imaging every 20 degrees. And at this step, therapists are supposed to verify the motion of fiducials compared to their reference positions. But this step is qualitative, as it doesn't give like numbers in terms of how much shift. And when there is an intolerance issue, therapists are supposed to call MD and physics and have a discussion, and they adjust the gating window and repeat the setup process until the patient can tolerate the new revised gating window. Or if the patient cannot do it at all, we have to go back to square one and replan for gating or free breathing. So I have a bit of time, so let me introduce the quality improvement effort going on in our hospital. First, it's led by myself. It's about prediction of DIBH tolerance, and we have another project about quantitative interfractional monitoring. So the motivation of this study was after seeing many patients that cannot tolerate DIBH, it causes not only delays the treatment, but it's also stress to patient and extra resources for resim and replan. So we need a better system to predict beforehand how well they tolerate DIBH. So my hypothesis was is poor DIBH tolerance at treatment can be predicted before they start treatment based on their patient characteristics and how they did at simulation, which we can know from the trace at simulation. So for this study, I recruited 82 patients that were treated in this period. And they are mostly liver or pancreas patients with some mix of fractionations and treatment sites. So the study endpoint was defined as any modification to DIBH protocol, including any change in breath flow level or resimulation for free breathing or gating. And for the predictive features, I extracted different metrics from their breathing trace at simulation, including the breath flow level and consistency between the first and the second threshold segments, and also the drift in the signal within a single threshold. Also, I extracted a bunch of baseline characteristics from the CIS or HIS, and all these variables were tested for univariate correlation, and also I built a multivariate prediction model. So it turned out that about 1/3 of the patient required some modification to our DIBH protocol due to intolerance. But for the most of the patients, their DIBH performance improved, as you can see from the average duty cycle, which is the percentage time that patients spent on breath hold. As a function of fractions, you can see the improvement over time. So over time, patients adapt to breath hold practice and they get better. And univariate correlation test shows the median breath hold level was significantly associated with intolerance. And this makes sense because the higher the breath hold level, it means the patient have to breathe even more to reach the level. So it makes more effort for the patients. And amongst the baseline characteristics, we found that the language they speak, their first language, is correlated with DIBH tolerance, although the p-value didn't come up very high. The odds ratio was the highest. And the p-value, the high p-value is explained by because most of our patients spoke English as a first language. So with a small sample size, we didn't have enough power to confirm that the language is a significant factor. And might be interesting to do this study in McGill, where there are two different language groups, English and French. But it's a side note. So the multivariate model I built predicted with AUC of 0.64, which is not, it has some room for improvement, but much better than random. And this is the variable importance plot, which means that which variables are used by the model to improve the prediction AUC. And it shows that the model uses more information from the trace rather than patient characteristics. So what I learned from this study was the DIBH tolerance can be improved by not setting the breath hold level too high, which is intuitional. And we thought before we started the study that patients with old age and such with some comorbidities will have a hard time tolerating DIBH, but it turned out that with appropriate coaching, this 85-year-old stage 3 pancreatic cancer patient can still tolerate this procedure. So patient coaching is very important. And the future work includes using this model to predict which threshold level will be best for a certain group of patients. And as I mentioned, we have 1/3 of patients that couldn't tolerate the DIBH. So gating is an alternative to the DIBH, but it's still underutilized because our MDs have this notion that gating takes much longer time and more burdensome for patients. But we have 2 internal studies that showed the respiratory gating takes only 2 extra minutes, but with comparable residual motion as the IBH, which was shown for upper GI and lung. So we are trying to convince our physician that so that more patients can be managed with gating instead of DIBH to improve their tolerance. So the last thing that I wanted to talk about is quantitative IMR. So as I mentioned, the biggest limitation of our practice for on-treatment monitoring is they can only visualize the residual motion, the therapist, without any number to act upon. And also, the on-treatment KV images sometimes have a poor image quality, so it's sometimes very difficult to see the fiducials or stents. And Varian has a product called AutoBeam Hold, and the product is quite neat for prostate, but their performance was not really shown for GI sites, and GI sites are more difficult because there are more motions, and there can be more stuffs like bowel that can make the image quality worse. And it's really difficult to customize variant product because they sell it as a black box. So our solution is the in-house software that can grab triggered KV images taken during treatment and analyze the KV images so that it produces the 2D registration error against the reference image to come up with this registration error from which the therapist can stop the beam if it goes out of tolerance. And what is cool about that is when it's used in conjunction with MVs, it can give 3D information. And we've been using this system for prostate for many years. And this study showed if we use this system, it actually improves the GI toxicity as shown in this graph. So we've been using this system for prostate, lung, and spine. And for lung and spine, we are working on a deep learning backend to enhance target visibility. And this is the example of the deep learning backend. And this study is done by one of our residents who recently became a faculty. And she built a unit-based deep learning model to automatically contour the stent implanted for pancreatic cases. And the accuracy is pretty impressive. And most importantly, after the model is trained, it takes almost instantly to make predictions. So systems like the models like this can be used real time to track the fiducials like in real time. So this model is being integrated into our in-house software and will be released in later this year. So to conclude, we talked about voluntary DIBH. It's a very effective and efficient technique, but we need to make sure that it always correlates with internal anatomy that we eventually are interested in. And when we use abdominal wall, we have to keep in mind that it's subject to many physiological noise, such as baseline drift. And all these uncertainties should be taken into account through inner PTB margin. And again, I have to stress effective patient coaching through visual feedback and the therapists play a big role in this, in that they tell patients not to breathe too deep or not too long. But it's always difficult to come up with a standard process and have everyone follow, even though we have the data that supports it. What I noticed from this making this talk is I looked through all the literatures, and there's not a single study that includes more than 20 patients to study DIBH response. And DIBH response is really specific to each patient. So every patient responds differently. But with a small sample size, it's really hard to see that. So I think that's where the AI tools are crucial to expand our data collection and find these patterns from every patient so that we have a true patient-specific model on how each patient respond to a DIBH. And from this, we can have a truly tailored DIBH for each patient. But we need more efforts, we need more AIs and tools. And I hope you enjoyed the talk and happy to answer questions.
Thank you very much for the very interesting talk, and it was very interesting to see all the improvements that can be done to reduce toxicities to patients. So now I will let the audience to ask any questions. Yeah, so there's so yeah, so is there anyone who wants to ask anything? Yeah, yeah, I think it will
Can you
be.
hear us in the room?
Yeah,
Yeah,
Yeah.
Can you hear me?
yeah.
Yeah, so I guess my question, I read a study a couple years ago that surveyed radiation oncologists and their use of DIBH in patients who don't speak English. So basically what they found is that centers were less likely to apply DIBH when patients didn't speak English. And I was wondering if that's the case in your center as well, or if with the kind of newer techniques where you can use that visual feedback and say provide a YouTube video ahead of time that's in their native language, if that's helped in applying it to second language speakers, or I guess, yeah, if you could just comment on whether or not those YouTube videos, for example, are available to patients in their sort of native language. I'd be curious to hear.
Yeah, it's a good question. I don't know if the educational videos are published in different languages. I only saw the English version. So the language is also issue in New York area. It's very multi-ethnic city. But MSK has a good resources to provide interpreters. So we have interpreters that are designated for different languages. So for this patient with non-English speakers, we have no problem getting interpreters usually. But regarding the question of MDs not reluctant to prescribe DIBH to non-English speakers. I'm not sure if there's a bias from the MD side, and there's something that I need to ask them. But in summary, we have good support to non-English speaking patient, but still, from my study, there was some effects from not speaking English. But I have to stress that my study, this study results were found before we introduced the visual coaching. So after visual coaching, we haven't had an official study about that, but anecdotally, visual coaching improved the tolerance a lot. So I think that's one of the evidence that language barrier can be greatly overcome by visual coaching.
Thank you. Is there any other question?
I see some
Yeah.
messages from the chat.
Yeah.
Okay, so question from Haley.
Yeah. You want to read it or do you want me to read it?
I'll read it.
Okay.
I was wondering how you and the MSK team feel about DIBH gating using SGRT system rather than the Markov block ones. So that's a very good question because we had an internal study comparing DIBH, comparing RGSC versus RNRT, which is surface gated, and the study showed the internal motion that we measure was quite comparable between the two methods. But the problem was about 1/3, maybe half of the patient, the RNRT or SGRT couldn't capture the surface because we always had to put the image up during treatment. So the interference in the case of SGRT was really an issue for using SGRT system. So that's why we went with the marker block one for abdominal and lung, but we use SGRT for breast cancer. So that makes more sense because for breast, we don't really need on-treatment monitoring during delivery. So there's no issue with interference with the KB.
Thank you. Is there any other questions? No question. Yeah, Morgan has another question. Go ahead.
Yeah, so my other question had to do with upright radiotherapy. I know there's a company that's been working on that in the States. And I think Stanford is getting a version of it for protons, but they have a system as well for conventional radiotherapy. And part of the argument that they use is that given patients are standing for most of their day, the effect of gravity on the liver is like the motion that you get in the liver is less significant when the patient is treated upright than if they're treated lying down. So I was wondering if you've thought about that at all or seen anything to that effect, or have any thoughts on how upright radiotherapy might benefit patients in the context of upper abdominal treatments.
No, it's my first time that people are investigating upright position. First time I heard about it, so it's hard to comment on comparing this versus supine. But in terms of gravity, I imagine that if we wait for 5 minutes, several minutes, the gravity will settle down. And at least that's what I found from literature. And usually takes at least 5 minutes from patient lying down and start the treatment. And therapists can always acquire the new baseline just before they beam on, so that any gravitational change during that wait can be corrected. But after we turn on the beam, there are chances that the gravity pulls the target in a specific direction. But that's why we keep the on-treatment monitoring so that we can detect such an error. And we have a tolerance of 3 millimeter when the position when the fiducial or marker that detect is off more than 3 millimeter, they stop the treatment and re-image and apply couch correction again. So there are always opportunities to correct for any drift due to gravity or other factors.
So just another question that I had, maybe it's a little bit stupid, but I will ask it anyway. Is there any training for the patients in order to ask them to do a more thoracic breathing versus an abdominal breathing? Sometimes we involve both, and sometimes we it depends on well, the person, I guess, and how they are used to breathe. Some people, they use more like thoracic breathing, and others, they like to involve a little bit more of the abdominal part of their bodies to.
Oh yeah, that's an excellent question, and that's a good question at all. So we don't coach patient to breathe in a specific way. We try to be as less intrusive
Okay.
in terms of their breathing pattern. But some people are naturally belly breathers.
Yeah.
I think belly breathers or chest breathers, in some cases we don't see any signal in the marker block when the marker is placed on the xiphoid, when the patient breathes from like lower belly. In that case, we have to move the marker block inferiorly to where the motion occurs most.
Mhm.
So we adapt the marker block position to specific to their breathing pattern, but mostly we place it on a xiphoid and it works for like 80% of patients, but the rest of 20% we have to strip the block down. So that's how we take into account different breathing.
Okay, thank you. Any other questions? No questions? Okay, so I think, no, there's no questions. I think no. Okay, so I think we can finish the talk today. Thank you very much, Q, for your talk. It was very interesting, and it was nice to see you again.
Yeah, thank you. It was nice to see you again.
Okay. Oh, bye.
Have a nice Friday.
Thank you.